Now, we all work the Rehab Options CPRC program, and it was Keith Schaefer that teed it up and created it, but it was really Tom that raised it and made it into the program it is today. Almost everything in the program was written and defined under his guidance. So we all deserve him a round of applause. I'm going to be talking about CPT coding. I'll do a PowerPoint presentation, but I wanted to point out on your flash drive are two additional documents that I thought you might find useful. One is a one-page reminder sheet that shows you on one page what all the different levels of documentation elements are in the E&M coding. So it's a quick, easy visual. I use it in front of me when I'm dictating or producing my notes. It lets me know what different levels of examination, medical history, and decision making. It lists the elements so I can make sure I fit in what I need to fit in to support the code I'm writing, and I wanted to provide that as something you might be able to use in your clinics. The second thing that's in there is an example of a progress note, and it's a layered progress note. I built it so if you look first at just the non-italicized, it's a lower level coding, and if you look at the italicized language, that goes to a higher level coding to give you a single concrete example of how different level of documentation justifies different level of coding. And there's a narrative at the bottom of it that explains it. I wanted to let you know those were there before I launch into the PowerPoint presentation, which will... Why is it doing that? You know, we get advanced software, and it's funny. I guess we're going to have to put up with the square. I apologize. I don't know how to get rid of it. Anyway, CPT means Current Procedural Terminology. It was developed by AMA, American Medical Association Committees, jointly the CPT Panel and a thing called the RUC, the Relative Value Unit Committee. Relative value unit decides the economic value weighting to add to different CPT procedure codes. It's also, so it's a partnership between the AMA and CMS that comes up with these coding standards. The E&M codes, starting in 1995, required a multi-system exam, and starting in 1977, introduced specially specific exams. So one key take-home point is there is a defined psychiatry-specific examination with defined psychiatry examination elements in the CPT coding nosology. This is a big change from the previous codes we used, 90862, 90804, 90805, or 90805, 90807. Didn't really have any definition, or if there were definitions, they were payer-specific. The definitions were not there by CPT. You know, who knows what I put in a 90862 according to CPT. They had no defined elements. The E&M codes have explicitly defined documentation elements that are expected, and there are an explicit set of elements for psychiatry as opposed to primary care. I will be presenting to you on CPT coding in general for all payers per CPT. Tom will speak about any nuances related to either Missouri Medicaid or nuances related to the Department of Mental Health. But I suspect that you don't always know where your primary billing is going to be going when you generate the note. You may be sending it to Medicare first. You know, it could go to any number of payers. So the training I'm going to give you is CPT absent any local delusions we've imposed upon it. No. So the first point I want to make to the physicians in the room is that documentation and coding is part of the physician, or in the case of advanced practice nurse, the prescriber work, that it is the prescriber, the person doing the service, that is responsible for the documentation and the coding, that coding is ultimately your job as much as writing the prescription. If the wrong code goes in, that's you, that's not whoever else you decided to involve in the process. The reasons that the codes were changed for mental health is that psychiatric codes, physician-specific, were coded the same as non-physician work. And this is in part an AMA collaboration, so it's more a physician guild issue, and there was a general issue on the part of the physicians to have physician codes separate from non-physician codes. Also, the payment levels for evaluation and management codes were steadily going up. They were getting rate increases on a regular basis. There was an ongoing undervaluation of the evaluation management component of psychotherapy with E&M. Prior to the change on January 1st, you billed for psychotherapy with E&M added on. Now you bill for E&M with psychotherapy added on. And there was a general trend nationally that even if psychotherapy went up, the E&M component was undervalued relative to other E&M work. The E&M component wasn't appropriately valued according to the RUC, the Relative Unit Valuation Committee. 90862 rates were either staying static or going down. They weren't being inflated. And there was nationally more and more payers that were doing restricted contracts, meaning if you were a psychiatrist, they would only pay you for 90862 and the other 908 series. They would not pay you for E&M codes, even though per CPT, any physician that meets the documentation requirements is able to bill that code. Certain payers, certain insurers would write a contract saying, I'm only going to pay you for these, I'm not going to pay you for these other ones. So a lot of this was really a billing approach to get payment parity. This was, in a large part, an attempt to get to parity. Overview of the changes that were implemented January 2013. The highest volume code we did in general, 90862, medication services, pharmacological management, was deleted. It's gone. Other key services have new code members that are described differently. All the new codes can be used in all settings. There are now two codes for initial evaluation, one with medical services and one for evaluation without medical services. They were using the same evaluation code whether it was physician or non-physician with medical services or not. Psychotherapy is no longer specific to site of service. Under the old coding, you had different codes for whether it was in the office or out of the office. Psychotherapy with evaluation and management is now instead an E&M code with a psychotherapy add-on payment. There's a new crisis psychotherapy code set, and the work previously described with a separate interactive code is now done using an add-on code, adding on the interactive workload to the general E&M or psychotherapy workload. So in the new nosology, there are two general choices for psychiatrists or psychiatric nurse prescribers. You can bill off the E&M codes, which are site-specific by inpatient, outpatient, consultation, nursing home, and residential treatment. Or you can bill off the psychiatry family of codes. E&M codes are used across all medical specialties. They're agnostic to specialty. The psychiatry code includes a specific evaluation code. So if I see a new patient, I can either bill them as a psych eval, or I can bill them as a new E&M code, depending on the documentation, the way I choose to do the documentation, or the way I choose to submit the bill. There are separate psychotherapy codes for patient and her family, family group, and the new crisis code, and there, of course, are still ECT codes. The evaluation and management codes are based on national guidelines starting in 1995 and 1997. As I said, they're psychiatric specialty exam that came out in 1997. A long time ago, like 15 years, we've had specialty exam. For the psychiatry family of codes, on the right there are no national guidelines, and the documentation requirements will be based on local carrier decision, meaning whatever the insurer you're submitting it to has for their guidelines, those are the guidelines that will apply. They are mostly driven by the local Medicare provider, whatever our regional Medicare authority, and I have yet to see any Medicare guidance on any of these codes. I'm unaware that Medicare has submitted guidance on what documentation they expect to see here. There is guidance on the E&M coding, but it's the same guidance we got back in 1997. It's not new guidance. So for pharmacological management, 90862 has been deleted. Psychiatrists and nurse practitioners are to use the appropriate E&M 99 series, 99212, 99213, 214, etc., or 205, so forth for new patient visits. There's a new add-on code, 90863, has been added to describe when pharmacological management is performed by a prescribing psychologist, which we don't have in Missouri, so you don't have to worry about that. But what you do need to worry about is 90863 should never be used by physicians. It is a psychologist code for the few areas where psychologists prescribe. So medical providers use evaluation and management codes for general office and facility-based visits. The E&M codes are replacing 90862. CMS has established guidelines. The codes are divided up between new and established patients, site of service, level of complexity, and the amount of work required. The amount of work required is driven by the presenting problem. One new requirement, if you bill an E&M code, you have to put in a chief complaint, a prescribing problem. That was not necessarily a requirement in 90862. It's a data element that you need to make sure is in your documentation now. What is the chief complaint or presenting problem? So the amount of work is driven by that unless you do counseling and coordination of care for more than 50% of the patient encounter. Then you select the E&M code based on the amount of time. So there's two ways you can select a code. If you spend more than half your time on counseling and coordination, it's a time-driven code. Otherwise, it's a work complexity-driven code. It really is a better way to code, but it's a much more complicated way to code. It's not simple, it's not straightforward. This shows a little comparison on the pricing between the old code, 90862, that had an RVU of 1.72 and in Medicare paid about $58, between the outpatient E&M codes, with 99212 having 1.29, 99213, which is intended to be the bulk of what we do, will most often be a 99213 or a 99214, coming in at a higher payment value, at least in the Medicare system. For the new psychotherapy codes, and you see them listed here, they are time-based. Psychotherapy codes are time-based, but they're no longer site-specific. There's not different coding by different site of psychotherapy. The psychotherapy time is face-to-face time with patient or family member. Time is chosen according to the traditional CPT time rule, and you can add on an interactive psychotherapy using an add-on code. Previously, interactive complexity was a separate code in and of itself. So now you would build the base code, perhaps 90832, plus an add-on code. So you would get an additional payment and you'd be billing two codes, and I'll talk more about that. The CPT time rule is that a unit of time is attained when the midpoint is passed. When the codes are ranked sequentially by times, like 30, 45, 60 minutes, the code you bill is the one closest to the nearest time code. So it is in ranges. So your 15-minute code is billed, your 30-minute code is billed at 16 to 37 minutes. Your 45-minute code is billed at 38 to 52 minutes, and then you see the hourly code there. An add-on code is a code describing work performed in addition to the primary service and is reported on a separate line. Add-on codes are never billed alone. Examples include psychotherapy with an E&M service, interactive complexity with either psychotherapy or with an E&M service, or crisis services. So E&M with psychotherapy is now reported by selecting the appropriate E&M code. It's interesting I put a question mark. It should be an ampersand, but it often is more a question mark. Service code and the appropriate psychotherapy add-on code. And the same time rules apply. The E&M code is determined by site of service, and the key elements performed, not the time. So if you're billing E&M with psychotherapy add-on, for your E&M portion, it's billed by the complexity of decision-making, the complexity of your exam, the complexity of your history. The E&M component is not time-based. Your psychotherapy component is time-based. So now you're generating a note where part of it is complexity-based and part of it's time-based. If no E&M services are provided, then you just use the psychotherapy code and it's all time-based. Interactive complexity used to be limited to just when you were using physical aids, translators, interpreters, or doing play therapy. that definition has been broadened. You can now bill interactive complexity in just when communication's more difficult. If you have people that are overly reactive and are arguing, if you have to call up and deal with insurance prior authorizations, generate documents to court's guardians, call up the teacher on the phone, if you have to do mandatory reporting because somebody told you they got abused, all of that allows you to do an additive interactive complexity. So here's the new CPT codes, interactive complexity add-on, psychotherapy codes for crisis. There are complex care coordination services, which most of the payers aren't covering right now, and transitional care management, which most payers aren't covering either. I won't go into them right now because the basic codes are complicated enough. That's for another presentation. So let's go into the evaluation and management documentation for psychiatric services by a physician or by an advanced nurse practitioner. You have different codes by type of service. There's different series of codes for initial visit, consultation, or existing patient. I'll be talking mostly about the existing patient codes because they're our highest volume. There are also different codes by site of service, inpatient, outpatient, nursing facility. I'll be talking mostly about the outpatient existing patient codes. Level of service for these is determined by either the history, exam, and medical decision making, by the elements, the complexity of those elements, or by counseling and coordination of care if it's over 50%. So on the documenting by the elements, the three key components are the history, the examination, and the degree of complexity of the medical decision making involved. The history and examination components are divided into 4 different levels: a problem-focused evaluation, an expanded problem-focused evaluation, a detailed, and then a comprehensive history and examination. The medical decision-making occurs at 4 different levels also. You notice there are 4 different levels, just as there are 4 levels of billing codes, 99212, 13, 1415. 4 levels of complexity, 4 levels of billing. Medical decision is straightforward, low, moderate, or high. So let's go into the history. You can see why I gave you the grid, the cheat sheet. There's a lot of elements floating around here to have in a documentation. The required history elements for E&M coding is there should always be something that says chief complaint or reason for encounter. Why are they here today? What are they complaining about? What is the purpose of the visit? Then there's the history or present illness, and they are specifically looking for some kind of description of either the location of the problem, the quality, the severity, the duration, the timing, the context, modifying factors, and associated signs and symptoms. So this would be, instead of saying they're depressed, you would say they're severely depressed, mostly at night. I've now added a severity comment and a timing comment. So I've added 2 levels of complexity to the fact that it's just depression. Review of symptoms. There are actually 14 different symptoms one can review. They're listed here: constitutional, eyes, ears, nose, psychiatric, and so on. Past family and social history. For a problem-focused exam, you just do the chief complaint and a brief history of the present illness, and you only need 1 problem. For an expanded problem focus, you again have the chief complaint, a brief history of the present illness, and you have to have a system review. You can't do an expanded problem focused without including review of at least 1 system. Detailed, in addition to the things I mentioned before, you have a review of at least 1 additional system, review of 2 systems. You always make review of psychiatric, right? We're going to say what happens psychiatrically. The easiest second system to make is constitutional signs. Sometimes we'll make endocrine because we ask people about their thyroid, about diabetic stuff. Also, a detailed history has to make some mention of pertinent past family or social history. So if I mention that they have severe depression more often in the morning since their wife left them 2 weeks ago, they continue to have conflict. I've now added a social history component and have gone up to a detailed level. It doesn't take much. You just have to make sure you hit the appropriate different topics. Comprehensive, you actually have to go do a review of all systems. I would not attempt to bill the comprehensive unless you're working off checklists. You'll miss something. So the history of present illness, for a brief history of present illness, it's 1 to 3 of the elements I listed there, commenting on 1 to 2 chronic problems. You usually want to hit location, severity, duration. Here's the elements listed below for all. For an extended, again, you need at least 4 of the elements below, and you need to comment on the status of 3 or more chronic or inactive problems. So is it depression? Is it sleep? Is it mood instability? All those are individual problems that could add up to get you up to 3 instead of down at 1 or 2. That's a brief overview of the history elements. Going up to the exam, as I said, CPT actually stipulates the elements for a psychiatric exam. I don't necessarily agree with them. They wouldn't be necessarily the ones I chose, but that's what's been in federal regs since 1997. The stipulated elements are orientation to person, place, time, attention span and concentration, recent remote memory, language skills, fund of knowledge, estimate of intelligence, speech, mood and affect, thought processes, associations, thought contents, meaning delusions, hallucinations, suicidal or homicidal, insight and judgment. The psychiatric specialty exam includes constitutional symptoms. So as a crucial part of the psychiatry exam, it includes vital signs. It's really good we're doing metabolic screening. You should be checking people's blood pressure, weight, pulse, and respiration, because you have to have 3 of 7. If the psychiatrist always comments on the blood pressure or heart rate that was gotten by whoever is assisting out in the waiting room, then you'll make constitutional signs. It's an opportunity to bill a higher level. Also, they included is gait and station. Does a person not walking normally and standing in one place steadily? Station is how well you stand. So my notes usually say the person walked in with a normal gait and stand with a steady station, and they appear to be of equal muscle strength with no tonal increase. And I move their arm a little if they're on an antipsychotic. If they're not on an antipsychotic, I don't move their arm. So the complexity of the exam, it's a problem focus, the lowest one if they have 1 to 5 of these elements listed on the previous 2 slides. It's expanded if they have at least 6 elements. It's detailed if they have 9 elements, and if you're going to build comprehensive, the highest level, level 4 codes, then you better have all of them. So we've done history, we've done exam, and to encourage you, those were the simple parts. The most important part, which is the most complicated, is medical decision making. It's the most important of the key factors. It reflects the cognitive work done by the physician. And there are 3 dimensions. So we have 3 things we're measuring, and the third thing has 3 dimensions. You know, it's actually harder to figure out the coding than what to do with the patient currently for me. The patient's easier than the coding. The dimensions for medical decision making are the nature and number of the problems, the extent of the data reviewed, and the level of medical risk. It's divided into straightforward decision making, low complexity, moderate complexity, and high level complexity. And the levels are based on the numbers of problems or diagnoses, the data reviewed, and the level of risk. I have another duplicative. I need to drop a slide there. So here's the grid. It's straightforward if there are minimal number of diagnoses or treatment options, if the complexity amount of data to review is minimal and there's no complexity. If I'm just refilling your Prozac that you've been on for the last 3 years, that's straightforward. Low complexity, there's limited diagnosis, but not minimal. Moderate complexity, multiple diagnoses, and so forth going up. The same with the amount of data that needs to be reviewed, and the same with the amount of risk. So when assigning a progress note, we're supposed to consider the number of diagnoses and treatment options, the complexity of the data we considered, and the risk levels. The level of the CPT code at the end of the day when you document by the elements is determined by the nature of the presenting illness and the number of elements documented under history, examination, and medical decision making. If counseling and coordination is more than 50%, then you do it based on time, unless you're doing a psychotherapy visit. Then you have to do it by the elements. You can't do 50% counseling and bill psychotherapy add-on. When you document by the time, when more than 50% of the time either on the floor or on the unit on inpatient or face-to-face and outpatient is spent on counseling and coordination, then time is the sole determining factor. Complexity matters not. The provider must document the total time that they were face-to-face with the person spent doing counseling or care coordination and dictate a summary of the encounter. The key components do not determine the level of coding. Now, counseling is defined as a discussion with the patient and or family caregiver concerning one or more of the following: diagnosis, prognosis, risks and benefits of treatment, instructions for management, compliance issues, risk factor reduction, patient and family education. It's pretty darn hard, in my mind, to tell the difference between how I would write a psychotherapy note and a counseling, care, and coordination note. And there's no guidance from CPT that's very clear on how to do this. This is the generic all specialty and primary care definition of counseling and coordination, and I think they couldn't figure out any clear, bright line to draw between it and psychotherapy, especially since there is no CPT national definition for psychotherapy. That's a local carrier decision. Remember, I told you there's no national guidelines for the new codes. So at least on the federal side, when you're working in Medicare, it's entirely unclear, in my mind, if I'm a psychiatrist, whether I'm better off, or if you could even argue that I was doing it wrong if I billed the same encounter one day as counseling and coordination of care and drove it at 50% time, as opposed to billing the E&M code and doing the psychotherapy add-on. This is confusing and complex, but I guess it also represents discretion we have in choosing how we do things, if you want to look at the bright side of it. Coordination of care is referred to as discussion about the patient's care with other providers or agencies. So I often actually spend time with the patient in the room calling up their other provider or calling up the pharmacy to get prior authorizations, and I'll chat with them while I'm on hold and we'll talk about stuff. And that's part of my time. When I do that time, then I may often bill a time-driven code or a care and counseling code, but it could add to E&M level of complexity because it could be interactive complexity. The problem we have is outside of this written guidance from CPT, carriers have not given much guidance on this. I don't think you should be able, I at least am not billing both interactive complexity and doing care and counseling if I spend time talking to outside parties. I think you could do either. To some extent, I'm uncertain, and I'm sharing my uncertainty with you. And when I've listened to other people doing this training, there are overlaps to how you can bill these things. So putting it all together, the history is a chief complaint plus a history of present illness, a review of systems, past and social family history. We went over the examination. You can do it by the elements or by time. So if we're going to select an E&M code, the key components should fit correctly within these documentation elements. We'll go ahead one. So in general, a 99212, lowest level, a level 2 code, the presenting problem or the reason for the encounter, NPP is presenting problem, RE is reason for encounter, is a self-limited, minor, transient in nature, not likely to permanently alter health status, or there's a good prognosis and management compliance. This is, I gave you a refill on your Prozac and not much is going on today. The medical decision making is straightforward. The medication's not particularly risky. You only really need one problem. They need a refill. The focused history, you only need to mention 3 of the history elements. It's hard to write much of anything at all without hitting 3 history elements that I showed you before. And the exam is just 5 elements. 99213 is low to moderate risk. The risk of morbidity is low, full recovery is expected, or there's moderate risk of morbidity and uncertain prognosis. There may be some functional impairment. The medical decision making is more complex, meaning there are either there are 2 or more treatments that could be considered. I'm not just continuing the same med. I'm going to decide, they're on 2 or 3 meds, and am I going to switch one of them to 2 or 3 other possibilities? It goes to moderate complexity when there is more than one treatment choice or more than one condition being considered. The history has to have 3 elements plus 1 review of systems. The examination has to have 6 to 8 elements. Most of my billing is 99213 and 99214. 99214 is moderate to high severity risk. These are people that may be having some suicidal ideation, recently discharged, have been getting sicker. We've done a bunch of recent medication changes. They may have 3 or 4 different diagnoses, maybe one of them medical. I'm considering whether I want to send them to therapy or switch their mood stabilizer or add an antipsychotic. So I have 2 or 3 treatment considerations across several illnesses, and things are not going particularly well. The history has 4 elements, plus at least 2 review of systems and at least 1 personal, family, social history element, something about what's going on outside in life or in the past. And the detailed exam has to go to 9 elements. For an established office visit, you have to hit 2 out of these 3 requirements between history, examination, and medical decision-making to justify that level of billing. For new patients, you have to hit 3 out of 3. So I just described the 3 levels and the multiple elements to get you at each level, but you don't have to have all 3 levels for a 99212. You have to have 2 out of the 3 for an established outpatient. For a new outpatient, you have to have 3 out of the 3. New patient, the high-level codes all require a comprehensive history, which requires at least 3 personal, family, or social histories and a complete review of systems. Remember, there were 14 different organ systems required. That's why it's hard for psychiatrists to generate notes that make comprehensive history unless you're using a review of system checklist document type of thing. The high-level codes all require a comprehensive examination, including vital signs. They require all 3 of the elements, history, exam, and medical decision-making, just not 2 out of 3. And here's a list of the different codes and the levels required. So I'm going to turn it over to Tom in a minute. Part of what I find frustrating is the electronic medical record I use, and all the electronic medical records I've seen used by everybody else do not have templates that embed these required documentation elements. So your EMRs are not supporting and facilitating the required documentation against which, if you are audited, your notes will be judged. I think we should all be twisting the arms of the EMR producers to change the documentation templates to explicitly have a place for chief complaint, history of present illness, to have fields to fill in for each of these required elements so it's clear. It's much easier if you're an auditor. I mean, right now my current progress note doesn't have a slot that says chief complaint because I have my old psych note and that just wasn't the way it was framed up. So I have to remember every time to dictate the person or to type in the person came in with a chief complaint of I'm crying 3 times a week now, whatever it is, because I'm looking to have chief complaint. It's a required element, so I want it prominent there. I think that's a huge administrative issue, and I think we need to all be twisting the arms of the EMR providers to get that support built into the EMR platforms. I'll turn it over to Tom, and he'll talk some about the specifics of how this is being handled with Department of Mental Health and with MoHealthNet, Missouri Medicaid. Tom? Oh, you don't need my iPhone. Yeah, they just keep going forward. Oh, I just added them onto the end.
Okay. Good afternoon. Thanks, Joe, for that overview. And I'm glad that he initially said that what he was going to do was give more of a broad overview of the CPT changes, from more of a national perspective and kind of get down into some of those details. Of course, as many of you, I think probably all of you know, we didn't implement all the CPT changes from January 2013 in this state. And I'm here talking more specifically about the CPR program with the division you deal with. Most of the decisions where we decided not to implement a part of the CPT code changes really weren't decided by the Department of Health, but we were really following the lead of MoHealthNet. Specifically, some of the parts we didn't add, for example, that Joe just talked about here, were the add-on psychotherapy codes and the interactive complexity codes. As it happens, initially when we were sort of mapping out a conversion plan back towards the end of calendar 2013 or 2012, we actually included those because we thought they probably should be implemented, but it was really a MoHealthNet decision not to implement those two key pieces. And really, sort of different states and different payers are either implementing everything or not implementing everything just based on our own, internal decisions. I can tell you, I think from the perspective of this state here, my impression was that the major kind of driver of not initially implementing those add-on psychotherapy codes and the interactive complexity codes was really driven more to the fact that, as you all know, none of us had very much time to get ready for these changes. And specifically, we have our data system that does our billing to MoHealthNet, which is CMOR. Obviously, Medicaid has their own system, their MMIS system, which processes claims. And I think really the main driver of the decision not to implement those two pieces was that we just didn't have enough time to make the kind of changes in our data systems to allow that. Now, I know in the 2, 3, 4 months after January, we got several questions. I got several questions from some of you all as to, when are we going to implement those? I can tell you, we went back to MoHealthNet, and the answer we got from them was, not anytime soon. So one thing I want to hear from you all, since you obviously deal with us and MoHealthNet, but you also deal with other payers, is if not implementing those two pieces, is causing some difficulty for you, you need to kind of let us know that. We can always go back to MoHealthNet again and talk about making some of those changes. But again, it's not something that would happen overnight. It's something we would both have to make some pretty significant changes in our data and billing systems to do that. So again, in this state, what we did basically was, as most of you know, we added, and I think I counted this up right, I included in your handouts a listing of all the new procedure codes we added. But if I counted right, we added 76 new procedure codes, basically the 99201 to 205 series, the 99212 to 99215, a set of the domiciliary evaluation management codes to use for persons in residential care facilities, and then some codes for the psychiatric diagnostic evaluation. And you get to 76 because we have different levels of staff providing those services, from advanced practice nurses to psychiatrists to child psychiatrists. One thing I wanted to update you all on today, and I believe this was supposed to have been announced at the fiscal officers meeting yesterday, was we do have a proposal to add some additional evaluation management codes for psychiatric residents. We just sent that proposal over to MoHealthNet about 2 weeks ago. We got some questions from them about that, as we often do, and we're in the process of answering those questions for them. This was originally brought up, I believe, by BJC and possibly by Truman also. There are a handful of providers in the state who do use psychiatric residents. Not everyone does, but some of them do, and we've been paying for that through the POS system. So we had another request from some of those providers as to why aren't we covering evaluation management codes for psychiatric residents in the CPR program. And we took another look at that and talked to Dr. Parks about it, and we all agreed we wanted to do that. So we do have a pending request that will add about 20 more codes for psychiatric residents to do evaluation management services. We requested a November 1st start date. I'm not sure if we're going to hit that, but basically we'll be giving you all an update on that as soon as we get approval from MoHealthNet. Then I wanted to go over a memo that came out just last week from Natalie Fernelli, who's here, just to sort of emphasize a few things and also cover one more new thing that's happened with respect to evaluation management codes for the Department of Mental Health. Is a month ago, I believe, or actually it was a couple months ago, we came out and talked to the coalition, and at that point in time, we reiterated to providers that we had not made any changes in either our policies or MoHealthNet policies regarding physicians needing to record the exact clock time for services, even after we made this change to the evaluation management codes. And we got some questions about that, and that caused us to go back and take another look at that issue. And so one of the main parts of this memo that came out last week was to notify you all that we reconsidered that, and basically the policy that we're going to be following now is that unless you're using that over 50% of counseling or care coordination in your visit, you do not have to include the clock time. There is that exception, though, in the CPT catalog where if your physician does spend over 50% of the time doing counseling and or care coordination, you are allowed to use the exact time in the visit to determine which code you choose to bill. And so we just want to make sure everyone understood that, and you can use that clock time in those cases, although you're going to have to make sure that you have it on the note when you use that exception. And again, my understanding is most of the time you're not going to be using that exception, but at least it's there in case you want to have it. But for most of the time when you're doing your medication management services and choosing a EM code to bill, you're not going to have to use that, not going to have that clock time. It's really your decision as to whether you want to keep including it for every medication service intervention you do, or whether you just want to show it for the notes that you need it on. Just a couple other things that I want to remind you people of that we covered before, that we emphasized again in this memo that came out, was we do feel it's very important for you all to be looking at the types of codes you're billing. The first time we looked at just statewide what was going on in terms of the frequency with which people were billing these codes, and we compare that to some national averages that have been used in some training material. We saw a lot of variation, and I came out and talked to the fiscal officer group about this before, and I guess what I would say is, just to reiterate that, is that my initial assumption was that there's probably not a lot of variation from one CMHC to another as to how you're delivering your medication services. So when we saw some dramatically different patterns in the percentages that were being billed to a 99212 versus a 99214 and 99215, we were a little concerned about that. So really all we did was we came out and we gave that information to agencies, and we asked everyone to take a look again at how you're billing those services and how you're choosing those codes. The bottom line is, however whatever system you have, and however you are choosing, whether to bill a 99212 versus a 213 or a 99214 versus a 215, the bottom line is you need to be able to sit down with an auditor and put two progress notes next to each other for different codes and explain clearly why you billed one versus the other. And that's the bottom line, is you should have your documentation aligned to do that. So I was glad Dr. Parks made that plug at the very end here to look at your EMRs and how we should be spending some time looking at that too. Because if your documentation isn't set up to clearly capture those key elements now, the history and the examination and the medical decision making, I don't know how anyone can sit down and explain to an auditor why you chose to bill one code versus another. The Department of Health has not looked at a lot of these services yet, although we are intending to start to look at some samples of them. We looked at a small sample of claims probably about a couple months ago, and again, one of the things that struck me when we did that was several of the progress note forms just weren't even set up to capture those basic elements, and I think those are agencies that really needed to examine, re-examine how they're collecting their information. And again, we talked about this to you before. But we did see some very good examples. I see some people from Kreider Center here. I do recall that we looked at a couple notes from there, and they had their documentation for their medication management set up really perfectly. It looked like it was modeled on some of the sample templates that the APA puts out. And I could very clearly, look at that note and see, okay, this is the area where they talk about the examination. This is the area where they talk about the history. This is the area where they capture information about whether psychotherapy or care coordination is involved in the visit. And so they had a very good example. And again, we've encouraged providers to look at those templates that are out there on the internet and try to model your documentation after that. So that's really, I just want to make a few, brief comments here, specifically, reiterating the information about how we are in the process of adding the psychiatric resident codes, and we do have, an updated view of of when you can use clock time, when you can't use clock time. So at this point, I don't know, Joe, do you want to say anything else, or do you want to take some questions?
Just to be a little more explicit, when we looked at those patterns, there were a couple agencies where every code was one code. It was never any other code. That's going to stick out. Don't do that. Don't do that. Beg your pardon? What? Yeah. So you have very consistent treatment. You produce very consistent patients, and we're going to find another provider. I think we're open for questions. Clearly this is. I had to read through this stuff several times to get my head around it. It is much more complicated way to choose elements and codes than our previous methodology. I think the only counterbalance is it's the way the rest of medicine's been doing it since the early 1990s, and separate's never equal. If we want to be part of the crowd, we do it like them. Yes. No, his question is, there's prolonged or limited functioning, and what does that mean in our context? The nosology was set up for primary care, primarily for acute care. It didn't contemplate how we do stuff at all. We're just fitting into it. What I do in my own practice is if they have had an exacerbation that I think is going to go on for quite a while, then I'll call it prolonged. If they're in an RCF or supported living, I'll call it prolonged. If it's just that, they have a lifelong illness like bipolar disorder, my primary care colleagues don't code every diabetic as a prolonged problem, even though it's a lifelong problem. So that's how I tend to think about it. If it is clearly impairing to the point where they're disabled or getting specialized support services, then I'm more likely to do it. But I bounce between 99213 and 99214 mostly. If I see the person and I'm just doing a simple refill and nothing's changing, then I'm more like, and I don't have to deal with any social or administrative tasks, then I do a 99212. I almost never do a 99215. I probably could, more often than I do, so I'm probably undercoding a little. I don't know. That's just what I do. There's Jaron. I think in the CMHCs, I would be choosing the psychiatric evaluation as opposed to the new patient E&M. If I do a lengthier evaluation, something like an hour, then I use the psychiatric evaluation code. If I'm doing the kind of brief evaluation I commonly do in my primary care practice clinic, then I'm more likely to use a 99205 or a 99204, the E&M codes. So, but I think for most of your new patients in CPRC, I'd be in the CMHCs, I'd be using the psych eval. I think particularly because there is no CPT stipulated documentation elements. It's all local carrier provider. So your requirements would roll over to whatever was in your DMH contract or whatever had been previously accepted by MoHealthNet anyway, since MoHealth hasn't given you any new compliance. I think it would be more complicated to run the grid to figure out what's required under E&M for new patients, especially if it's a longer, higher level coding. In the back. Hang on just a second. I'm going to come and bring you the speaker because I'm having trouble, which means nobody's hearing. Yeah, 90792 is a psych eval with medical services. No. So the question is, does it say what those medical services have to be? Essentially, that is the code that's intended to be used by physicians, the other ones to be used by psychologists. Now, in Medicare, there's actually a billing rate problem that probably will not get addressed for another 18 months or so. They did not calculate the medical component correctly when they added it on to it, and so it is undervalued. You actually get paid less for the psych eval with a medical component than without, and that actually was an out-and-out administrative error in how the Fed ruled it out, but it probably will not get corrected for another 18 to 24 months. So on the fiscal side, you actually may want to build the E&M codes instead. I haven't crunched the numbers between the spread on the two of those. Jaren, you want to make a comment on it? Is it substantial?
The 99200 codes, like the 99205 is $205.42, whereas the 90792 per unit, I guess if you do 4 units, it would come out to be about the same.
Yeah, because the unit's 5136. So you're about, yeah. By units, so 4 units comes out within a couple bucks of each other, not worth the sweat over it. That the psychiatric evaluation with medical component, when they do the next, at the latest in 2 years, the RUC, the Relative Unit Value Committee, is going to do its routine review of all the psychiatric code valuations, and at that point it'll undoubtedly get revalued and will become significantly more lucrative. But, you know, got to wait for federal action. Hope they don't get shut down. Yes, my PowerPoint should be on your flash drive. I've modified it a little, and it will be it'll be available on the website also. Yeah. You know, if you don't have an EMR that facilitates seeing these particular elements, then use a cheat sheet. There's a couple of different cheat sheets on your flash drive. There's the one that I showed you initially. There's another one that somebody else produced. There's a bunch of them out there that list all the elements in one place, but I can't remember this stuff unless I have it on a sheet in front of me as I'm generating my documentation. I wouldn't expect anybody else to remember it off the top of their head until they've done it 5 years straight.
We did laminated sheets, so our doctors have that in their hand, and it's going to hold up better than just a single sheet of paper, so that they can have all of the different possible choices.
You want to send your version to Brent too, and he can make it available along with my version, and they can decide. You know, people can pick and choose.
I think ours is pretty similar to yours, but we can do that. Yeah.
Okay. That's okay if everybody circulates. If the versions are congruent, that's better than if the versions are discongruent.
Is it on here, or has it been distributed, or is it going to be?
Your PowerPoint should be on the flash drive, and my PowerPoint will be reposted on the Coalition website. Yes?
I have a question based from the auditor's perspective and trying to do chart reviews for some of our doctors, and I'm wondering if you would see a problem with some of the higher level codes being used based on medical decision making, maybe a medication that needs to be monitored for toxicity, so the lab work's involved, a community support worker's involved, there is a disability from the illness, 1 or 2 diagnoses, and a thorough exam. However, the mental status, they're at baseline, they're stable, their chief complaint is, I'm doing okay. And so the current symptomatology, they're stable. Yeah. But yet they're billing at a high code because they are meeting all the elements. Do you see red flags going up?
I think if it was in the context of somebody that had problems and was now stable, that would be defensible. I think if they've been complicated for 2 years, and you've been doing detailed monitoring for 2 years, and they're always stable. So I don't think just because you've had somebody on clozapine, and it's common to have clozapine patients that get case management and get blood monitoring, and they've been that way for 5 years, and you haven't changed the dose, and but they do need the monitoring. I don't think I'd be doing a 215 on them all the time. If you've done some adjustments, you've had, or they're new on it, certainly, you just, don't push the envelope too far. Yeah. Other questions, observations, error detection of things we've said that are incorrect from what you've heard elsewhere? Good luck, it's complicated. We'll try and be helpful. Thank you.